name is Dennis Whitaker. I'm one of the student doctors here. I'll be seeing you first.
All right, so for this review, we're actually going to recap just the ending portion of episode 1 as it's a continuation into a few of the things that we're going to talk about in episode 2. All right, so in medical school, you're referred to as student doctors. So sometime during medical school, you're going to rotate through emergency medicine for the first time. For me, it was my third year of medical school, followed by all the rotations in emergency medicine my fourth year.
Nice to meet you.
BP's 150/90.
Okay, that's just a touch high.
I forgot to take my damn Analopril this morning.
Oh, we'll get that for you.
Tell me about this belly pain.
Started about here. Pretty intense. Lasted about an hour. Now it's gone.
All right, so when the med student's evaluating the patient here, they're currently asymptomatic. This does happen. Patient checks into the ER for chest pain, stomach pain, whatever it may be. But by the time they see a provider, the patient has no symptoms. So this does happen.
Any fever, vomiting?
Nah, I never get sick.
Now, the patient here states he never gets sick. So we can't infer from this the patient has no past medical history or surgical history. We have to ask those questions. I've had countless patients that come into the ER like, I don't have any medical history, and it turns out they got heart failure, they got diabetes, they're on dialysis. They say, Doc, I don't think I'm on any meds. And you find out, no, they're on 30 medications. So you have to be very thorough, but at the same time, you have to ask the right questions. Otherwise, you're not going to get the answer.
Okay. What did you eat last night?
Oh, it was my wife's birthday. Took her out to Sullivan's for a steak.
Oh, okay. Well, the exam is pretty benign. I'm gonna test for gallstones. If there is a stone and you eat fatty food, there can be pain when the gallbladder contracts.
So in the ER, we do have a focused physical exam, but you still have to ask the right questions. And some patients require just a few more questions based on how they're presenting or even the age of the patient and their risk factors.
Oh, bingo. 1 stone, there it is.
So this is a great bedside ultrasound. Looking at this, you can clearly tell in the ultrasound that the echogenic focus within the gallbladder lumen with acoustic shadowing, there's no signs for any pericholecystic fluid, so we don't have any gallbladder wall thickening either. So with this, I would say, hey, there's no signs for acute cholecystitis. Again, at least what I can see from the ultrasound on screen. But this ultrasound does look like your standard cholelithiasis or symptomatic cholelithiasis.
Do I need surgery?
You should be able to manage with a low-fat diet, but we'll send off labs.
So one thing with this case is that in the ER, just because you find something, just because you diagnose something, sometimes immediately, doesn't mean that that was the diagnosis that brought them in. There are other mimics. So in this case, most likely based on the clinical presentation, the physical exam, the patient's history, it was most likely gallstones, but at the same time, you're still considering other things, which is why the med student in this case, ordered blood work, he ordered an EKG, just making sure it wasn't anything else. So this was smart, this was very good.
For liver and pancreas, just let us know if you have any more pain.
Now, if a patient is asymptomatic and they just have cholelithiasis, so they have gallstones, typically they're discharged. Any procedure that's done is all done on an outpatient basis. Now, if a patient presents and the gallbladder is infected or there's an obstruction or, this is their 4th or 5th visit to the ER, typically they're going to get admitted at that point and that gallbladder is going to come out.
Okay. Thanks.
Yeah, you bet. Great.
You want an EKG?
For,
Heart attacks can present as upper abdominal pain.
yeah. No, yeah, that's a great idea. Thank you.
So I love this. Nurses are the true rock stars of the ER. And honestly, I think they're all underpaid and grossly underpaid for what they do. And if I had my way, I would increase all of their income. And this goes for all nurses in general. So for the nurse here to suggest an EKG is absolutely amazing. This kind of tells you the seasoned nature of this particular nurse. So with chest pain, we have really 2 types. We have typical chest pain and we have atypical chest pain. Your typical chest pain is your classic squeezing pressure, left chest. It radiates down the left arm into the left jaw. But realize your atypical chest pain, these are patients that are least likely to present with those symptoms. And it's really 5 patient populations. Your female, your diabetics, your elderly, but those with a prior CVA or those with previous congestive heart failure. These patients are most likely to present with shortness of breath, upper abdominal pain, dizziness, chest achiness or chest pins that's been constant. So a little bit different than your typical chest pain.
Where are we going now?
We need the room for someone else, but you can rest in the hall till we get your labs back.
Parents must be proud. Having a son who's a doctor.
Yeah, I guess. You know, I was the first one in my family to go to college, and they sacrificed a lot to get me here. How's your pain, Mr. Milton?
I'm fine. Could use a latte, though.
That could bring back the gallstone pain.
How about a bourbon?
It's barely 8 o'clock. How about some ice chips?
No, thanks. I prefer my whiskey neat.
Yeah, that's not happening.
So moving patients into the hallway is actually pretty accurate. If you have a trauma 2 patient, for example, that was just stabilized, maybe they're awaiting bed placement, you decide to put them in the hallway because you have a higher acuity patient coming in. Maybe the bed situation is low. You have this gunshot coming in. You need to get them into one of the trauma bays. So it's not uncommon to move a patient at least into a lesser acuity room or potentially into the hallway as well. So in this case, the patient here was completely appropriate that he was placed into the hallway. It sounds like maybe some of the labs were still pending, but he was asymptomatic, laughing, smiling, joking, currently no symptoms. So this is a patient that was perfectly appropriate for the hallway, at least temporarily.
Got something?
Oh, I had a case for Dr. Collins.
May I see it?
Yeah. 68-year-old male, history of hypertension, 1 hour of right upper quadrant pain after eating a fatty meal, now resolved, afebrile, non-tender. There was a gallstone present on POCUS.
So here the med student is going to staff with the resident, and instead he gets to staff with the attending. So it's really fun, especially if you get a cool attending that you get to staff with.
EKG shows no acute ischemic changes, but I'm still waiting on LFTs and lipase.
Why did you order the EKG?
The nurse suggested it to rule out any cardiac issues.
Well, good call on both your parts.
So here he's absolutely right. Shout out to my ER nurses. The amount of STEMIs and NSTEMIs that I've had that have came through triage where the patient presents with shortness of breath, they present with back pain, upper abdominal pain, some of our atypical features, and an EKG was done because of that. And then the EKG is given the attending and you look at it and you're like, no, this patient's having a heart attack. Let's bring him back right away. The amount of times this has happened is actually pretty alarming.
Nurses know what they're doing. Never hesitate to listen to them. Come find me when those labs are back.
Yeah.
So in other words, always listen to your ER nurses. Again, if I had my way, I'd give all my ER nurses a raise, all nurses for that matter. Right now, a lot of nurses, they may get like a pizza party in the ER from management and things like that, when in reality, yeah, the pizza party is cool and all, but let's do a raise and a pizza party. I think, everybody is going to appreciate that one.
Sorry, we had to move you into the hall. I know it gets pretty chaotic and noisy out here. Mr. Milton? Hey, Bennett, wake up for me.
All right, so if you recall, this is actually the patient that was placed in the hallway earlier because he had resolution of all his symptoms, and we were kind of waiting on labs, it sounds like. In addition to that, we needed room for some of the higher acuity patients coming in. So this, again, is a continuation of that. Now, as an attending, these are very difficult cases, and this is a patient that you're going to think about for a long period of time. Now, realize what we actually know a little bit later on is that this patient did have a normal heart enzyme, so they had normal troponin, they had normal labs, and they had a stone cold EKG. And they were waiting in the hallway for some remaining stuff to come back. So again, they were completely asymptomatic. This is a patient that likely, would have been discharged already, and they would have went home, went to sleep, and had a massive heart attack when they went to sleep. So likely this was unrelated to his initial ER visit. It just so happened that both happened at the same time. So this is unfortunate, but these are cases that you're going to think about for a long time.
Oh, shit. I need a little help here. Help!
When did you check on him last?
I don't know, around half an hour ago at most. I was waiting on labs.
What's going on?
It's my gallstone guy. You saw his EKG.
Unknown downtime, he was sleeping in the hall. Crash card, let's go!
So this patient was found essentially in the hallway, no pulse, and they started CPR. Only if you recall from my review of episode 1, this is not CPR. CPR like this will save absolutely nobody. So last episode, I talked about something I called TP-CPR. So television princess CPR, basically the art of advertising a realistic medical drama only to perform unrealistic CPR. Again, we have realistic bodies that can be used for this. In addition, if the editorial cut is just right, we can give that appearance. So please take a look at my review from episode 1 that included a segment on CPR, the appropriate depth, the mean number of ribs broken during CPR when it's done correctly. So definitely feel free to check that out.
I got it.
Hold compressions. Asystole. Resume compressions.
Amp with Epi. Slow temper.
Should I intubate?
No, drop an element. We don't want to hold compressions.
So I cringe every time I see this CPR. This is honestly probably the worst CPR portrayal in television history. This is terrible CPR. This will save nobody.
Pupils are fixed and dilated.
Been down a long time.
Seriously, guys, can we just change the editorial cut completely? I mean, we're just focusing on this CPR for such a long period of television that it's horrible to watch. And it looks like now it's back to just horrible CPR. The other thing to watch with this is his angle that he's doing CPR. So in reality, we actually have stools that you stand on so that you're actually a little bit further above the patient, so that when your arms are doing CPR, when the hands are on the chest and you're going down, you have a downward kind of traction. And so that way you're able to give consistent and appropriate CPR, and you don't get burned out as easily. So you can take a look on the screen. I kind of put the angle that you're supposed to be at. And he just needed a stool to kind of stand on.
We switch out every few minutes. You can take a break.
I'm fine.
Hold compressions.
So every round of CPR, you do need to switch out. You're doing this for the fatigue factor. You continue CPR long enough, and again, you're not going to maintain that consistent, accurate CPR. You want the same repetition over and over again. And so in this case, likely he was kind of feeling guilty because it was his patient, and that was the patient that died. So in reality, he needs to just switch out. Just let someone else and just take turns. You know, even if it was every other attempt, just do that.
Still in asystole.
Resume compressions.
Well, should we shock him?
You don't shock asystole.
We could be fine VFib.
Not a chance.
Okay, when was his last epi?
3 minutes ago.
Okay, well, ACLS says every 3 to 5 minutes, right? So let's push another ramp.
Fine.
Robbie, Mr. Spencer's adult children are asking for you, and the parents of Nick Bradley, the fentanyl overdose, also want to speak with you.
3 rounds of Epi and then call it.
No change.
No pericardial effusion, no tension, pneumothorax, no cardiac activity.
Let's try calcium. Could be hyperkalemia.
No, his potassium was normal. You ready to call this?
Not yet. Dr. Robbie said 3 rounds of epi. It's time. Let's push another amp. This one could do it.
In the first 2 episodes, we talked about something that I coined TPCPR, Television Princess CPR. This is the art of advertising a realistic medical drama only to perform unrealistic CPR.
Oh, shit.
What?
I think I just broke some ribs.
Means you're doing it right.
Trust me, dude, you're not breaking anybody's ribs here. In fact, you actually may break my heart watching you attempt CPR. If you recall, CPR has been going on for quite some time. This patient's been in cardiac arrest, underwent numerous rounds of CPR, and we are just now hearing about a broken rib. I'm sorry, but at this point, there should be nothing left to break. If CPR has been done correctly, the first round or 2, whoever is doing CPR, those first few rounds, those are when the ribs get broken. So if we are just now hearing about a broken rib this late into the game, that tells me the CPR that was done earlier was just done incorrectly. Because again, we should not be having any broken ribs this late in the game. So not realistic.
3rd amp of Epi's on board.
Come on.
Call me if there's a resurrection.
Now, if you watch my review from episode 1, I talked about the mean number of ribs broken during CPR, which is 7. And at this point, there will be no ribs broken with CPR like this. So again, not realistic.
3rd Epi on board.
3 minutes ago.
How long has he been going at it?
10 minutes in here, possibly 30 minutes of prior downtime.
Don't suppose you'd let me try a pericardiocentesis
For what?
for practice, in case it's tamponade.
I'm seeing an ultrasound.
This is a teaching hospital.
It's not like a dabber lab.
What do you call this?
Do you need a break?
I'm fine.
You don't look fine.
Hold compressions.
Still no rhythm.
So at this point, this is basically 40 minutes of asystole. This is 40 minutes of a flatline. So as much as the medical student does not want to give up, mortality of this patient is 100%. Now, it's one thing to have VFib, a known downtime, a younger patient, no risk factors, or even PEA for that matter, but 40 minutes of asystole in this patient is 100% mortality. And I think that either the senior resident or the attending should have called time of death here. The reason that I don't think they did is that since this is a teaching hospital, they wanted to see the medical students step up and make that call in terms of time of death. And so when I was a resident, it didn't matter if I was a first-year resident, second, third, or even my chief year of residency of a 4-year program. When we are residents, sometimes that attending wants us to be able to step up and to make that choice. And I know for a fact, I look back now, there's times where I'm like, man, my attending could have stepped in and he could have called it, but I kept going with it. And it's because he was trying to teach something at that point. So I think here that was probably the reason they let the medical student just continue to go, even though the mortality was 100%.
5 minutes since the last epi. Okay, that's it. Hold compressions.
So in this scene, they called time of death. Now, as much as we want to save lives in the ER, as that's what we're trained to do, we identify the emergency, we treat the emergency, and we try to save a life. But sometimes you have to call time of death, and it never gets any easier.
He took his wife out for dinner last night. For her birthday.
Okay, why doesn't everybody take a minute, go check on your other patients? We'll meet back here to debrief with Kiara.
Come on, man. You heard Dr. Robbie. Let's take a break. Grab a coffee.
No, I'm fine. Thank you.
Sometimes on a night shift, let's say you have a few hours on shift where the volume is lower. Now, I won't use the Q word. It's a bad omen, but I'll put that word on the screen. I just refuse to say it in the emergency room. But you're in the room quite a bit. Let's say it's a gentleman on hospice. You know, he's got metastatic lung cancer, family's present. They tell you about his military history, how many great grandkids he has, the names of all his dogs over the years, you know, that it was just his birthday and your staff was able to sing him happy birthday. When he passes and you call time of death, those moments are some of the hardest moments that you're going to experience in emergency medicine.
What else went well?
We checked for reversible causes of cardiac arrest on ultrasound.
So they're doing a debrief here, and sometimes these are done with nursing staff as well. Other times at teaching hospitals, these are done with residents to kind of recap the case. What was done? What could have been done differently? What can we do to prevent anything from happening again? You know, what did we learn about this case? This debrief can also serve as a way to kind of cope with loss as well and kind of really get you to process the entire situation. And I mentioned it earlier, but one of my last cases in residency was a child where, you know, it's a very sweet family. They were actually going to be moving and there was a large dining room table. You're talking one of these massive dining room tables leaning up against the wall. The kid ran into it and then the table landed on the head, ended up with an open skull fracture. And so this is one of those where I coded that patient for over an hour before finally calling time of death. And I can say that that debrief was something that everybody in that room needed. That was a case that I would go on and think about for days. It's been years now, and I still think about it every now and then. And I think having a debrief in a case like this is very good, and this was very realistic.
Okay, good. Does anybody have anything that they wish had gone differently?
In the hall. You should have been on a cardiac monitor. We would have caught the arrest right away.
That's true, but there was no indication for monitoring.
So while this was true, not every patient is placed on a cardiac monitor that's in the hallway. So in this case, the patient was asymptomatic. There was clinically no indication to put that patient on a cardiac monitor. Now, it's one thing if the patient has chest pain or shortness of breath and they're placed in the hallway, they're going to be on a cardiac monitor. So in this situation, there was no clinical indication to place that patient on a cardiac monitor.
And we now know that his abdominal pain was not from his gallstones, but from unstable angina due to coronary artery disease.
Now he states here, now we know the patient didn't have symptoms related to gallstones, but from unstable angina. And really it could go either way. So this is a patient that either had pain related to gallstones, now asymptomatic because he had negative EKG, negative troponin, and he just happened to have a heart attack later, or these were atypical anginal equivalent symptoms that we talked about earlier. So again, this could have been two different things and not necessarily related.
Then we should have admitted to cardiology.
We did an EKG, we did a troponin.
So it's revealed here the patient had a normal EKG. The initial troponin was negative. Now, a troponin is a heart muscle protein that looks for potential damage to the heart. Now, it can be elevated for a multitude of reasons. One of them, though, is cardiac ischemia. So depending on the marker used, typically a troponin will start to rise within just a few hours of true cardiac-related chest pain. This is actually why some patients get 2 troponins to evaluate that trend. The patient's first troponin may be normal, but let's say the second one comes back considerably elevated, or the patient has a normal first troponin and the second troponin is normal, but the third troponin comes back very elevated. Typically, the patient will end up having a cardiology consult and possibly a heart cath to identify the blockage and get treated.
He had a heart score of 3.
So here he mentions the heart score. The fact that a heart score is mentioned at all on a medical drama is impressive. Now, he says the heart score is less than 3. I think he meant to say heart score is less than 4. Now, 3 is still low risk. The heart score helps predict the risk of any major adverse cardiac event. That's MACE, major adverse cardiac event. And that score is going to take into consideration a patient's clinical history, their presentation, the EKG changes, the age of the patient, the risk factors, high blood pressure, diabetes, smoking, high cholesterol, things like that, even a family history. So a low score is 0 to 3 points. Now, had they have had a second troponin and it was elevated, that score would have been different as well. The patient would no longer be considered low risk, and the patient would have needed intervention like admission, cardiology consult, a stress test, possible heart cath, etc. However, again, there was no suspicion this patient was having any cardiac ischemia, as the story in the physical exam did not support any cardiac etiology. So realistically, getting a second troponin probably wouldn't have been done. Now, if the patient still had symptoms or they had other symptoms like chest pain, chest achiness, or even worsening abdominal pain, a second troponin probably would have been done. And at that time, then you can tell, hey, is this more gallstone-related pain or is this truly cardiac-related etiology for the symptoms?
Who can tell me what that means?
1% chance of an adverse cardiac event in the next 30 days.
Standard of care is to discharge with outpatient follow-up.
So here he states a 1% chance of MACE or major adverse cardiac event in the next 30 days, which means a 1% chance on having a major adverse event like a heart attack in the next 30 days, for example. That actual number is 0.9 to 1.7% chance. A few studies will state 2.5%, but for the sake of percents though, it's much easier just to tell patients 1%, but obviously that does vary based on a few of the studies that are out there. The original heart score study was for 6 weeks, not actually a month. And there have been plenty of validation studies as well, systematic reviews in terms of percent and treatment. So small critique here. The concept was spot on. The concept was accurate.
He was your patient, Dr. Whitaker. Would you like to say something before we all take a brief moment of silent reflection?
He liked Kentucky bourbon.
Okay, good. Me too. Anything else?
I don't know. I just met him. No, he seemed nice. He was married. That's it. That's all I got.
I spoke with his wife. She's on her way here. If anyone needs to talk about this some more, I'm available.
For now, let's harness some good thoughts here for Mr. Milton.
So I'll say this every time they do a moment of silence after somebody passed. I think this is amazing. I think it should be done every single time. Again, you're showing respect out of someone that just passed, but you're also doing it to help everybody else that was a part of that case really talk about it and really cope and kind of find their peace before moving on to that next case.
Okay. That's it. Let's go save some lives. Hey, Whitaker. How are you feeling on this?
I mean, not good. I was just talking to him. Now he's dead.
It's the hardest way to lose a patient. Always hurts.
Especially when it's your fault.
This was not your fault. This was nobody's fault. No doctor on the planet could have caught this.
When he says here that no doctor on the planet could have caught this, he's absolutely right, but he's referring to the fact the patient had no symptoms, had a normal EKG, the first troponin was normal, and the heart score was less than 4. Standard of care, he's correct. It's outpatient follow-up at this point.
Listen, it sucks, but today was this guy's day to leave this mortal coil. 150,000 people die every day in the world, and you got one of them. But you learn to live with it. You learn to accept it as much as your own mortality and find balance if you can.
You found balance.
No, not even close. But you keep trying, which is all you can do. You're doing great. Whitaker, just, hang in there.
Yeah, thanks.
Okay. I'm just gonna go.
Yeah.
But our social worker, Kiara, is here if you want to talk.
Okay, yeah.
You could not have predicted he would have had a massive heart attack in the hall based on all that. It just so happens he was in the ER at that time, although asymptomatic for possibly, gallbladder-related pain. Now, kind of on another extreme example, you can think of it this way. Grandpa passing away at the nursing home from a heart attack, and you're like, man, Grandpa was just seen in the ER earlier that day because of an ingrown toenail. He was just seen 6 hours ago. Now, he wasn't having atypical symptoms related to a heart attack. He was just in for something else, and it just so happened to be a horrible coincidence. So again, was this a horrible coincidence, or was this atypical related pain?
Best just to grab one and jump back in.
Yeah, right.
Mr. Fulton in Central 14 just needs a shot of my Lancet for his GERD to avoid eating foods with the words flaming hot in their title for at least a few days.
Okay, thanks.
Central 14.
Yeah.
So if you recall from earlier, he actually lost his very first patient and has been thinking about it for a while now, which is completely normal. Realize the biggest way to help with things is just what he stated. It's to pick up another patient and jump back in. Realize there's no delay in the ER. You keep moving. Patients just keep coming back, keep coming back, keep coming back. It's not going to stop. You're not going to get a 2-hour break at a heavy trauma center and hope that you can get some lunch or hope that you can get some coffee. Patients are just going to keep coming. So the biggest thing that you can do is just pick up that next patient and hope that you can save their life and just keep moving forward. And sometimes this is very difficult because you're compartmentalizing what just happened. He just had a case, patient died, ultimately patient had to be pronounced. And as an ER doctor, you're trying to compartmentalize that. You're trying to shut that off. When that next one comes in, you have to be 100% on that case. You cannot be doing a procedure on the incoming patient and thinking about the case that just happened. So you're all in on this new one. And I think this is something that takes not weeks to develop, not months to develop. This will take years to develop to get to the point where you can have something so bad happen, whether it's a gunshot, a stabbing, something that is just vivid in your mind that you're forced to turn that off and to focus on this next case.